talking from the angle of internalized and other aspects of stigmatization and how it impacts, really is a hazard. I like to use these dramatic words like danger and hazard because I think often people talk about or think of stigma as like an unfair and unkind thing, which it is, but also it's actually a dangerous thing. So, and how it's another one of the obstacles and hazards to equity and care access and outcomes and engagement and all like that. I took a little bit maybe of a lighthearted approach to this because I just ran across this stock picture and love the idea of Ignite. Like it's so great, as someone said in the introductions, to be able to cross-pollinate or to ignite, collaborations and new ideas connecting, across all of us, and of course, bigger networks that we're all part of. And so I was a bit selfish in saying that my main point is asking for suggestions, connections, trying to develop new projects to address the things that I'm going to talk about. And I start out in mental health, and then, of course, everything is connected. Also working some, or trying to work some, in addictions, in trauma, break down these divisions since people's lives are not lived in these categories of challenge, as well as the intersectionalities of identities, as well as health conditions. So I start from this idea of stigma. I actually tend to use the mouthful stigmatization because I think it focuses us on the fact that this is a social and interpersonal process that we do to each other, rather than stigma as something that someone has. So I kind of go back and forth with those terms. I think that it's important to notice that prejudice and discrimination themselves harm mental health. And as Sean's, presentation was a great example of, affect treatment, support, engagement, and all of those things. So we have this social environment that really needs cleaning up because it itself is dragging down our recovery from these other health challenges that are quite burden enough for the individual and families and communities. So I started using this term of stigma as social pollution because it's an apt metaphor for a number of important points. One of which is that, so we're trying to clean up the air or the social environment, and we are making some progress, although it's very slow going. And in the meantime, we all have to walk through the imperfect or polluted environment and navigate that as best we can to, in this complex fabric of prejudices and realities and challenges and identities, in order to try to get to the best outcomes for ourselves. And of course, when we're talking about health services of any sort, that is, a major goal. People aren't responsible for the harm that pollution causes to them. The individual is not responsible, but yet is left to deal with the consequences. And so when we're talking about something that's this broad and this convoluted, like the smoke and the pollution in this picture, I find it helpful to take things apart a little bit in terms of stigma or stigmatization. One of the areas that I've been focusing on is this idea of internalized stigma. The idea that if on the left silhouette, you think about the black dots being pollution and the fact that it's hard to not take that into your lungs, I'd say in the polluted social environment, it's hard for us to not take stigmatization into our thoughts, whether that is mental illness stigmatization or whether it's internalized racism, internalized homophobia. There are some really important common parallels amongst a wide breadth of internalized oppression, even at the same time as there are some really important unique aspects and distinctions. Thinking about the issue of internalized stigmatization that has really dangerous impacts. So on top of the burden of the polluted environment, then you have this in your own thinking, and it's been shown to clearly relate, again, like another whole layer of deterrent or obstacle in terms of people getting the access that they need, people reporting what's going on with them in ways that help themselves, whether it's underreporting, overreporting, any of that disclosing to people who might be of help in terms of non-professional supports, and sometimes for very sensible reasons, but also just in terms of persistence in coping, just in terms of the gumption. And Pat Corrigan, one of the big people in internalized stigma and mental health, talks about the why try effect, that it can be so demoralizing that you don't, like, why is my life even worth persisting in trying to make things better? So internalized stigma is one facet that's particularly dangerous. And we know some things about what makes people resistant to it versus high risk for the corrosive effects of internalizing it. And so we try to share what we do know in interventions and resources and things like that. But of course, there's also a lot more to figure out to really hone that and make it the most effective. Another facet that has both commonalities across all kinds of internalized oppressions and unique aspects is this idea of anticipated stigma, that the expecting to be stigmatized is enough to cause fear, anxiety, and avoidance of various things. And of course, this is really sensible. Why would you not be hesitant or even avoidant if a certain environment, person, situation is so often going to cause you, distress, trauma, perhaps danger? Again, Sean's, some of his presentation is a good example, but there's many, many of them. So that an interesting complexity of anticipated stigma is that it is logical and self-protective and very sensible. And at the same time, it can get overgeneralized or met with hostile environments and insufficient coping resources. So it's really inhibiting and isolating to a person's life. So you don't want to just say it shouldn't happen, but at the same time, how can we help prevent or help people dig out from the iatrogenic effects of that? One of the ways that I've been trying to put those and other ideas into action in practical ways to help people navigate the polluted social environment more is we created an intervention, a psychosocial sort of class called Ending Self-Stigma, that you can sort of see some of the details here. It has spawned a number of other resources. The idea was to take everything that we could find out from research, from clinical work, from lived experience, from other paradigms, and I often describe it as, mix it up in a bowl, bake it in a loaf pan, and slice it into 7 practical strategies that we try to help people learn and then ascertain whether would be useful to them in this class. This particular intervention has a couple of randomized trials behind it and is used nationally and even a bit internationally, both in the VA system and in community mental health, with recent pilots for adapting it to veterans with PTSD, and a recently funded but not even hardly started pilot for adapting it to the needs of people with opioid use disorders, particularly who are using medication treatment for opioid use disorder and have justice involvement, as a collaboration between myself and Shannon Gwynn Mitchell from Friends Research here in town. Also a stalled project, a thwarted, frustrating project of trying to, again, use ESS as just a base for some ideas about fostering stigma resilience and resistance among people dealing with first episode psychosis, and how that intersects with a lot of the health and outcome disparities in first episode psychosis care. So generally, I have been using ESS as one base of trying to tackle these issues because it seems to have some, effect, but certainly not the only base of intervention that I am wedded to. So where I'd like to go, and in the interest of this being a think tank and fostering collaboration and such, is these are some of the things that I'm working on. I think I've mentioned most of them already, but think tanks are often for the obstacles and opportunities that are involved in getting to those goals. So, we tend to be siloed even in how we address mental illness versus addiction versus trauma, much less the even more complex things. I have some good connections in the community, however, not so strong in addictions and trauma, and also just the time to develop relationships and funding. So I've already made a couple of notes of people to follow up with after just from this particular meeting, but I would love your ideas, suggestions, and questions.